Thank you, everyone.
Now we'll go ahead with another bout number 19. Thank you so much, all speakers and chairpersons and co-chairpersons. For bout number 19, I would like to invite Dr. Shashi Mundra, Dr. Raghu, Dr. D.B. Solanki, Dr. Nikhil Jadhav, Dr. Saurin Shah, and Dr. Sanjeev. I would like to request Dr. Bhagirath to kindly introduce speaker.
Yeah, Dr. Our first bout 19. Good morning, and thank you, Dr. Kamal Sharma, for providing me an opportunity to be here in this conference, CardioCon. For this bout, the speaker is Dr. P.K. Hazra, who is DM and DNB cardiology. He is associated with the Medical Super Specialty Hospital and Ruby Hall General Hospital, Kolkata. He is specialized in interventional cardiology and cardiovascular surgery. His medical interests are angioplasty, angiography, atherectomy, stents, and peripheral angioplasty. So he is a truly interventional cardiologist, and he is going to talk on a very peculiar subject. That patient which has been given here is a 60-year male who is diabetic, hypertensive, strong family history, has a CV stroke 4 years back, completely recovered, and now 1 year before has IWMI and had put 3 stents. He is coming for follow-up. Apart from his medical optimization of therapy and lifestyle, what can be added over and above the aspirin, whether rivaroxaban or ticagrelor? And for that matter, Dr. Hazra is going to speak for 10 minutes about the addition of rivaroxaban 2.5 milligram BID over and above the aspirin and other medical optimization therapy for the patient. Thank you very much. Over to you, sir.
Kindly introduce Dr. Hemang Bakshi also.
Sir, yeah, for the next, this blue corner is our famous Dr. Hemang Bakshi. He is a very eminent cardiologist from the city of Ahmedabad, interventional cardiologist and director of SIMS Hospital, postgraduate in medicine from the my own BJ Medical College from where I belong, and gold medal in the DM cardiology. He is authored many research papers and had extensive experience in the field of clinical interventional cardiology. He performed more than 5,000 PTCAs and is one of the pioneer in the primary angioplasty in Gujarat. He received the prestigious fellowship of American College of Cardiology and fellowship of European Society of Cardiology. So truly a very experienced person. And after the Dr. Hazra, Dr. Bakshi is going to talk for ticagrelor over and above the aspirin plus medical optimization therapy for the same patient which we have already talked. Thank you very much. Over to Dr. Hazra, sir.
Thank you. Please allow me to share my screen. Please allow me to share my screen.
Yes, sir. Please, sir.
Yes, sir. Your screen is already there.
Okay. So thank you, Dr. Sharma, for inviting me. And case is already been shown there. Now, you know, this CAD is just like having a pimple on this beautiful face.
So your screen is not visible. It is a whiteboard. Please open your presentation first and then share the screen.
Now, can you see?
Yes, yes.
Yeah. Now it is visible.
Okay. So thank you, Dr. Sharma. CAD and many other cerebrovascular disease or peripheral vascular disease, I'll come back to CAD. This is just like a pimple on your face, and it can be treated, untreated. There's necrotic rupture, stress, food, many things are important. So lifestyle is very, very important to keep your simple pimple not disgracing your face. So you have a stent and you just cover one pimple. If you have 2 stents, you cover 2 pimples. And if you have 3 stents, you cover 3 pimples. And these pimples are basic information for our case to understand what I'm going to say. If you take this case, 60 years, there are some trials which fits into it. The red color tells you that it doesn't fit into that trial. They take more than 65 years. In Compass, they take enrichment criteria if somebody is less than 65 years. Diabetic, inferior MI, hypertension is not there in Compass trial. Stroke is not there in Pegasus. If somebody has a stroke, so this patient does not fit into Pegasus trial. Pegasus talks about multivascularity, Compass talks about polyvascularity. The strong families is not there in both the trials. Dyslipidemia not there. CKD is missing, which is a very important component of Compass trial. With this, may I propose a score for this patient for my convenience, like a Chadwell score. CCA is more than 65 in non-Asian and more than 55 in Asians. So he gets 1 point diabetes. And if he has got stroke and multivascular coronary artery disease, he gets 4 points. And if he has got 4 points, it's a solid case for DPI, not DAPT or SAPT. Now, I have very, very low threshold to prescribe DPI in these patients. Very rarely, patient will escape my prescription of DPIs, typically this patient. Now, if you talk about A, B, C, D, E, F, G, H, I, J of polypharmacy or monotherapy, you have many drugs which can brings your death down 9%, 2%. An outlier is here that it reduces death and stroke by 42%. And close by another molecule we just finished talking about, 32% plus increasing stroke with empagliflozin 18%. So what are these molecules? These are basically DPI, empagliflozins out here. Now, this is basically evidence-based, whether lipid lowering, whether blood pressure lowering, everything is important. But what is more important, to choose the right drug for the right patient in right time for the right period of time. And if you continue to choose the best drug like DPI way, rivaroxaban 2.5 milligram plus small dose of aspirin, perhaps on the top of your lifestyle modification, you can make it better. You can make it 82% relative risk reduction. That is amazing. Unfortunately, we do not have any marker for these rivaroxaban plus aspirin combinations like LDL. So this biomarker or the biotargets are absent. That is the only drawback. But you have the same drawbacks for your DAPT or SAPT regime. So both are at same level of lack of evidence. And this data came from her, not from a randomized clinical trial. It came from a registry, the DAPT. And this DPI is very important. Initially, we thought that DAPT is more important. Now we think that DPI or thrombin, which is the most powerful platelet agonist, is very important after a few days of angioplasty, 12 months of acute coronary syndrome. When you treat a patient, we do not treat only the molecule or the cellular level. You also treat the society as large. So in the society, if you give this molecule, you will prevent many debilitating stroke, amputation, so on and so forth. And this is the history, and the history is very beautiful of DAPT, but the history just began with the trial which has been stopped prematurely. You cannot name any DAPT trial, SAPT trial, any combination of antiplatelet trial because of its overwhelming benefit, like Jupiter, Sprint, Paradigm, Credence, Femi, and DAPA CKD score trial. You have only one trial on this antiplatelet, antithrombotic, that is Compass trial. And the DAPT duration, again, topsy-turvy course. So there is a confusion, but now we are moving towards shorter DAPT. Initially, we had clinical inertia. We had some kind of myths, some kind of stigma, because we have done some historical mistakes, like having BMS, having Cypher-like stent, having Texas-like stent. And when we used to put this stent, we used to prolong DAPT because of incomplete job, a wrong judgment. Now it has been much more prudent to do complex PCI with imaging. So it is just like I could not fix the brake, therefore I made the horn louder. So this horn louder means longer DAPT. Definitely this imaging helps, you see better. Now many people still live in medical tribalism. That means they still believe nothing can replace DAPT. We are a special group, needs preservations. We are indispensable. We are the gospel truth. DAPT is the only truth. That is not true anymore because you have evidence from Compass trial that it reduces CV mortality, all-cause mortality. So that is beyond any doubt. Whatever may be the number is excellent and beautiful. We have only one molecule in 2022 which has shown its beauty, whether it's vein, whether it's artery, whether it's pulmonary artery, whether it's brain, or the atrial fibrillations. So it's a beautiful molecule. So now you have a freedom of choice to choose between 2 DAPT or 2 antiplatelet, aspirin plus ticagrelor. So in this case, you have aspirin. Now, the other one is also another antiplatelet, that is clopidogrel, prasugrel. But you should go for the best, that is Pepsi or the rivaroxaban. If you have more risk factor, you gain more. And this benefit is usually disappears, ticagrelor versus placebo from trimestral at 6.5 years. So beyond this period, what takes the upper hand is the DPI. And we bleed more, and we bleed more on DAPT. So East bleeds more than West on DAPT than DPI at the cost of ischemic risk, but the ischemic risk is very small. So I would prescribe DAPT. Many patients face this kind of rapid CV, sometimes like appendicitis, fracture. This emergency situation is much easier to handle than DAPT. Now, this is a trial which is controversial. If you bring down your LDL, which we very often do, bring it down to 40 or 50, 55. If you bring it down with ticagrelor, you bleed more. If you bring it down to 54, perhaps that is the threshold. So you bleed more on ticagrelor with lipid lowering. Again, this is new information. So Japan, they do not use ticagrelor at all. They believe clopidogrel. So after the master that, we're moving toward SAPT single-handedly. But if you move, if you really want to go fast, go alone. If you want to go further, go together with a little boy, a little elephant, that is rivaroxaban 2.5 milligram. These benefits accumulate over time. So you go longer with this molecule. So if I want to finish here, for those who believe no explanation is necessary, for those who do not know explanation is possible. I'll finish with a short story that world champion relay race final. The US 4 girls were favorite, and they were one person who won 100-meter sprint, another one 200-meter sprint. So the odd was in favor of US, 43.59 and 44. But at the end, if you see that the blue represents French moving with the baton, ultimately the French team wins this relay race. But how they won? Look at her legs is as good as US, but look at the change or handover of baton and the strong command. So handover was excellent and beautiful. You can argue the future, but for me, then you perhaps going for path of immortality. So DPI is the only way to go. Thank you for your kind attention.
Thank you, sir.
Now, Dr. Hemang Bakshi.
Okay.
Dr. Hemang Bakshi.
Yes. Good morning, everybody. Am I audible?
Yes, but screen.
Yeah.
No slides. Dr. Hemang, your slides are not visible.
Yeah.
Now, yes.
But you are not seeing, Hemang.
Yeah. All right. We'll start the video. So, thank you, organizers, Cardicon, Dr. Kamal Sharma, for inviting me for this nice debate, and thanks, Dr. Hazra, for attractive talk. Now, I will discuss my viewpoint on ticagrelor 60 milligram BD with aspirin in this patient. Just a minute. So we know the patients, right? He is having multiple risk factors, has got stroke 4 years back, and has got multivessel PCI, and has got inferior IWMI before 1 year. I would have loved to have some further details like EGFR of these patients, what are the ongoing medications, does patients have PAD, and what was the type of the stroke the patient suffered from. But anyhow, let us discuss the science. I don't have those beautiful pictures, but I will stick on to the science. whether there is a need for long-term ischemic protection post-MI, and how does the long-term ischemic risk rise. And if you look at the various data, the REACH registry shows that there is in patients with in the patients with ischemic events, there is, quite high long-term risk of ischemic events, further ischemic events over 48 months. And this is the Apollo registry, which showed that approximately 20% of the patients had the risk of subsequent MI following 1 year of myocardial infarctions over next 3 years. And this is the placebo arm of the Pegasus trial, where it was observed that the MACE incidence was 15% up to 72 months after myocardial infarctions. And this risk lasts and continues up to 7 years in this IMPROVE IT trial. What about the patients with complex PCI patients? We know that patients who had undergone complex PCI, they have got significant higher rates of MACE, MI, and stent thrombosis over a period of time. So these are the patients which have got a significant residual risk, and we need to do something. And we have this DAPT study which showed that the reduction in the ischemic events was significant when this clopidogrel was given for long term up to 36 months in these patients. And this is the results of the, this is the Pegasus TIMI study, which studied patients more than 50 years with history of spontaneous MI 1 to 3 years prior to enrollment, and at least one additional risk factors, that is age more than 65, diabetes, second prior MI, multivessel CAD, and chronic end-stage renal disease. They were included, and they were given long-term ticagrelol. And the study, we already know the results that the long-term 60 milligram ticagrelol has got a significant benefit over aspirin alone when it is given beyond 12 months. And this reduction in MACE is complemented by individual endpoint reductions, that is CV death, MI, and stroke significantly, as you can see over here. Major bleeding was expectedly high in ticagrelol 60 milligram arm, but the fatal bleed or ICH were similar between these two arms. And most important thing to remember is that the greatest benefit of this ticagrelol is when it is initiated within 2 years of prior MI. So earlier initiation of ticagrelol gets benefit. As you can see, the Pegasus TIMI 54 analysis, you can see that irreversible harm, that is CV death, MI, stroke, ICH, and fatal bleeding was significant. 14% reversal is there. And that is why the guidelines have accommodated this recommendation. And you can see that ACC, AHA, as well as ESC has given class 2B indications in patients who are medically managed and not having high bleeding risk for giving ticagrelol or antiplatelet, second antiplatelet agents more than 12 months up to 36 months after MI. As you can see in ESC guidelines, ticagrelol is the clearly preferred over clopidogrel, not in the ACC AHA guideline, while in patients who has undergone PCI and they are not having high bleeding risk, again, it is a class 2B indications that this ticagrelol should be given beyond 12 months in these patients. Now, we have to identify the high-risk patients who can benefit the most with this long-term dual antiplatelet agents. And these are the patients who are having more than 2 risk factors, and they benefit the most. And our patient has more than 2 risk factors. He is diabetic, and he is having multivessel disease. So he is definitely going to benefit more when this ticagrelol long term is given. And as you can see, these are the risk factors. Patients which are having this, they get the greatest benefit. And if you have more than 1, 2 risk factors, then the benefit is definitely going to be high. But at the same time, you have to exclude the patients who has got high bleeding risk. So this is a very good algorithm. So step 1 is you assess the bleeding risk. The patients who has got prior hospitalization for bleeding or patient who has got low baseline hemoglobin, they should be excluded. Then you find out the risk factors. If the patient has got more than 2 risk factors, then they are going to benefit the most as far as the, you can see the MACE is maximum benefit in patients who has got multiple risk factors. CV death, all cause death, again, best in patients who has got multiple risk factors. And our patient, it fits in this criteria, because you can see this, that patient has got multivessel disease. He has got diabetes. We don't know about the renal impairment. Patient is definitely not having, multiple prior MI, but with these two risk factors, history of MI before 1 month, ticagrelor 60 milligram BID, 3 years post, up to 3 years leads to significant 34% risk reduction in CV mortality and 21% risk reduction in CV death, MI or stroke. Now, coming to the other molecule that Dr. Hazra discussed, rivaroxaban, you can see the comparison of the trial that 100% of the patients with Pegasus TB 54 had prior MI, and median of 1.7 years since their qualifying MI, while Compass trial had 62% patients with prior MI and mean of 7.1 years from their index events. Though our patients resembles more with this Pegasus TB 54 trial patients. At the same time, the MACE was definitely reduced with rivaroxaban in Compass trial, but you can see MI was slightly high, although not statistically significant, but stroke was significantly increased in these patients. And our patient also had a stroke, so we should be careful while giving this rivaroxaban in this patient. And this is the slide showing efficacy versus major bleeding with the rivaroxaban. Bleeding is definitely high, but more worrisome is that in this study, it was shown that bleeding was associated with increased risk of cancer. We don't know, it may not be causative, it may be just a coincidence, but you can see that number of cancers, new cancers, proportion diagnosed after bleeding was much higher, whether it is GI cancer or genitourinary cancer. And the cancer was diagnosed early, that is within 6 months after the bleeding, as you can see from this slide. And the author's conclusion was that among Compass patients with vascular disease on long-term antithrombotic therapy, more than 1 in 5 new diagnoses of cancers are preceded by bleeding, and GI bleeding and GU bleeding are powerful predictors of new GI and GU cancer diagnosis respectively. More than 75% of these cancers are diagnosed within 6 months of the bleeding event, and this should be kept in mind, and you should be careful for that. So in summary, epidemiological studies confirm that our patients with prior MI remain at high risk of major adverse events up to 5 years after the event. DAPT with ticagrelor 60 milligram per ASA reduces this risk, but at the expense of increased major but not fatal or intracranial bleeding. And a simple patient selection algorithm in which patients' predictors of high bleeding risk, that is anemia or prior history of major bleeding, are first excluded, and then the remaining patients are stratified according to the number of ischemic risk factors, may be useful to identify patients more likely to derive greater benefit from treatment with ticagrelor 60 milligram per aspirin extended beyond 12 months. Thank you very much.
Thank you, Dr. Hema.
Now the house is open for discussion. If there are any questions from anyone.
I think I would, not a question, but just making the things more simpler, that platelet is the cornerstone of the treatment, means antiplatelet agents. Now adding the something which is going to affect the coagulation cascade, that is a rivaroxaban, whether it is going to benefit, it is a very attractive hypothesis. But as Dr. Hemang Bakshi already in his lecture said, that there is increased bleeding risk naturally, because you are going to block the platelet and coagulation cascade both. And every bleeding risk is within few months is going to be diagnosed as the malignancy. So that is, I think, is again a matter of concern, but I think there are more light should be thrown on this aspect if anyone else can do that.
Yeah, I think the bleeding, he has rightly mentioned, that goes in favor of DPI regime rather than going in favor of DAPT is sometimes a blessing in disguise. If somebody is on DPI, as he has rightly mentioned, you pick up more GI cancer or your urological cancer, bladder cancer earlier, because you will be putting them on cystoscopy, upper GI endoscopy. So if you pick them up early, so it's a kind of blessing in disguise. And second, somebody who is living in a rural area, and he has a hematuria, and on the telephone, if you ask you, doc, I'm having hematuria bleeding, I'm on DPI, one patient, another patient is DAPT. If you ask them to stop DPI because of short-acting rivaroxaban, he is actually protected from the very next day. But on the other hand, which is ticagrelor regime, that he is not protected for 5 to 6, 7 days, as I have mentioned. During emergency surgery, somebody who is on DPI is much simpler to handle than the DAPT, CABG, or appendix, or a ruptured gallbladder. So these people are much more safe to deal with surgical emergency. So definitely I'll go for DPI.
But sir,
Basically, if you talk about this particular patient has got multivessel stenting, patient has suffered inferior MI before 1 year, patient is having multiple risk factors. So in this particular patient, Dr. Hazra is right that rivaroxaban is a good molecule, but I would, I would be hesitant in giving these patients who has got multiple stents to give. I would prefer to give antiplatelets rather than anticoagulants over a longer period of time. And rivaroxaban, I would say that it's a good molecule, but in patients with chronic coronary syndrome, or patients who are low risk for post PCI, in those patients, it's a good option. But in this particular patient, we should be giving ticagrelor.
I think fantastic talks, both of you. The point was to drive that the Pegasus data is driven primarily by patients who have had MI, which this case has. Stroke is something which is significantly reduced by rivaroxaban, not so much by ticagrelor. That was the other tilting point for the rivaroxaban, and MI was the tilting point for ticagrelor. That's why the whole debate. And we do get scenarios like this, but now we have evidences emerging even for acute stroke for ticagrelor. But remember, there the dosaging is 90, not 60. So that was the another highlight to bring out. I think both of the speakers did fantastic deliberation on this. But I would just ask both of you, if this patient had, suppose, another episode of TIA, what would be your next strategy? If he had a TIA, what would happen to the two therapies that you're giving? First, Dr. Hajra, and then Dr. Bakshi.
I think you have nicely mentioned the stroke is the outlier. Pegasus did not have any stroke patient, so he doesn't fit into Pegasus-like patient. If I want to choose my death, I'll never choose stroke. I never choose dialysis. I'll never choose cancer. Rather, I want to die from acute myocardial infarction, which is painless death. So stroke is devastating not only for yourself, for the whole society and the family sometimes. So stroke is important. If you have a stroke, you have 80% reduction in the another stroke. So if somebody was on DPI, I wish he is taking the medicine, the chance of getting another TIA is very low. If he gets a TIA, you have to investigate again the carotid and the other sources of embolism. And you can go for ticagrelor for the brief period. And later on, when the things are getting nicer, you can go back to DPI. Thank you.
I think Dr. Rajiv Agarwal wanted to make a comment. I think.
Yes, I'm sorry. Thank you. I'll say two simple things in just less than a minute. Once the atherosclerosis moves out of the heart, you tilt towards DPI. If it is confined to heart, it is simple DAPT. But if you look at the COMPASS intervention data, about 1,000 patients, that also favors in PCI, multivessel disease confined to heart, a DPI. That is another subgroup analysis. Of course, it is not a double-blind, placebo-controlled trial. So I'll say I'll go more for DPI than DAPT. There is no mortality reduction with DAPT. That is one thing which attracts me.
Right. So it's like a pimple. You get pimple on your face, pimple on your back, pimple on your neck. So it's not restricted to always on the heart. Thank you, sir.
So thank you. Brilliantly said. And your talk was brilliant and with lots of good examples, brilliantly presented. Very nice talk. Thank you.
Thank you, sir.
Thank you.